Next presentation is visual outcome in pediatric posterior lenticular cataract, a new classification of PPC by Dr. Anupama JANARDHANAN. Is she here? Okay, welcome.
Very good afternoon to eminent judges and friends. I'm going to talk about, I'm Dr. Anupama JANARDHANAN, pediatric ophthalmic consultant presently with Arvind Eye Hospital, Tirunelveli. A prior study that we conducted over a decade with pediatric cataracts, we found out that pediatric lenticular opacities are having much poorer outcomes. This helped us dwell much in detail into the subtypes of posterior lenticular cataracts. So we wanted to understand the morphological subtypes, visual outcome, and clinical characteristics. And we also intend to suggest a new classification for ease of diagnosis, surgical management, and prognosis. These were the characteristics we studied and the statistics we ran using SPSS software. Now what we found was there was a clear male preponderance and right eye was predominantly involved. Unilateral cataracts were more commonly seen and naturally a visual outcome following cataract surgery was statistically significant. But however, we found that improvement in amblyopia treatment was statistically significant only in bilateral cases compared to the unilateral cases. It was disheartening to note that more than 42% cases presented to the hospital after 1 month of onset of symptoms. However, almost 13% cases were picked up on school screening, and most common presentation was defective vision. Common association was anisometropia and exotropia. There were a couple of cases with PHPV as well. We were fortunate enough to do in-the-bag implantation in 93% cases. Now, these were the subtypes we classified, these 9 categories, and depending on them and also the outcomes we observed, we intend to give a new classification for posterior lenticular opacities. They can be broadly classified into 3 categories. Simple posterior opacities, mainly PPC, PSCC, or a combination of PPC, PSCC, where definitely we must ask for any steroid intake or any other common associations. And when it comes to surgical modification, one must be prepared for PC polishing and primary posterior capsulotomy irrespective of age. Now the second category is much more complicated, which includes lenticonus with associated PPC or a plaque, or PSCC associated, or with a PC dehiscence. Now these cases we must rule out Lovis syndrome. And why we say that? Because on retrospect, 4 of our cases were diagnosed with Lovis syndrome after the lenticonus was diagnosed ocularly. And a surgical expertise is definitely mandated for managing these cases. Also, standby 3-piece IOL and a standby VR support might be indicated. Now, when it comes to prognosis, dense amblyopia can be anticipated considering the unilateral representation that is commonly found. And coming to the third category, that is complicated posterior opacities, the ones which present like a total cataract but also has an associated lenticonus. And if we are able to pick them up pre-operatively, nothing like it. And the PPC which are associated with PHPV, an intraocular cautery which is available intraoperatively might be helpful in these cases. Now, what we already know is, as per Giovanni et al., PSCC had a better prognosis compared to posterior lenticonus. However, we also found that PHPV and preoperatively, if anisometropia is there, they are associated with poorer visual outcome. As per Young et al., pre-existing PC dehiscence warranted sulcus-supported implantation. However, only 3 of our cases needed placement in sulcus due to meticulous preoperative evaluation. As per Rashpe et al., 32% cases were diagnosed as posterior lenticonus on table. However, 78% of our cases, the PC defect was picked up preoperatively. So what we know is usually if a thorough preoperative evaluation is done, we'll be able to ensure that the IOL can even be placed in the bag, and we can try to save the PC as well. Only a few of our cases, due to eccentric nature of the PC dehiscence, sulcus fixation was warranted. In conclusion, why this study? Because nowadays, not just pediatric ophthalmologists, plenty of general ophthalmologists and adult phacosurgeons are also operating on these baby eyes. So what we expect them to know is at least classify those posterior lenticular opacities and be prepared to have all these difficulties intraoperatively. Also, it will help them do the parental counseling as to what to expect, how dense the amblyopia will be, and to follow them up or give a proper amblyopia management. Thank you.
When is the posterior lenticular opacity visually significant?
Ma'am, when it is over 3 millimeter in size, ma'am.
Okay, that has to be mentioned. It's
Yes,
a
ma'am.
very basic thing. Second question, you gave the third classification as total cataract. So how you are getting seeing the VPC in total cataract?
Ma'am, preoperatively, a couple of our total cataracts were also having the fishtail sign, but however, the children, they were adolescents, so we were able to do a B scan properly, and that helped us anticipate it at least intraoperatively, and it was verified intraoperatively as well.
And what about lenticonus? What are the syndromes associated with lenticonus?
Ma'am, anterior lenticonus Alport syndrome, so syndromic association, but however, in Loeys is what we commonly found in our cohort.
Okay, thank you.